Hi, everyone. Thank you for joining us at Virtual KFF. Today, we'll be unpacking the prescription drug provisions in the Build Back Better Act. I'm Tricia Newman. I'm a Senior Vice President at the Kaiser Family Foundation, and I'm Executive Director of our program on Medicare policy. I don't know about you, but I've really been looking forward to our session today. This briefing is being recorded and will be available in a few hours. Everyone who registered will receive an email when the recording is posted. Also, a quick reminder, if you have questions, please submit them in the Q&A function that you see on your screen. We'll be sure to save time at the end to take your questions. For the next hour, we're going to be talking about the major prescription drug provisions in the Build Back Better Act. These proposals are part of a broader set of policy changes that passed the House right before the Thanksgiving break. All eyes are now on the Senate to see if the bill will be modified and how and when there might be a vote. Drug costs are not a theoretical issue for families. More than 60% of Americans take at least one prescription drug, and among seniors, it's closer to 90%. Drug costs are on the agenda because it is a pocketbook issue, particularly for people who rely on high-priced medications to manage one or more serious medical conditions, but struggle to foot the bill. According to our polls, 83% of the public say the cost of drugs is unreasonable. 29% say that in the last year, they haven't taken a prescription medication because of costs. And 26%, 1 in 4, say it's very difficult for them to afford their medications. And drilling down to the more than 60 million people on Medicare, the Part D benefit has certainly helped to make medications more affordable, but prescription drugs can still be enormously expensive. In part, this is because the Part D drug benefit doesn't have a cap on out-of-pocket spending, which means there's literally no limit to how much someone might pay over the course of a year if they have spending above what's called the so-called catastrophic thresholds. This disproportionately affects people who take high-priced specialty drugs for serious conditions like cancer or MS. Just last week, I got a call from a friend whose father was prescribed a drug for cancer. His particular type of cancer required an expensive medication. My friend's dad was shocked to learn he would need to pay more than $12,000 next year under any of the drug plans available in his area. To put this in context, median income for people on Medicare is about $30,000 per person, and his situation is far from unique. Of course, high-priced drugs and annual increases in drug prices can be a concern for people of all ages, not just those on Medicare. And we'll hear today how the BBBA, the Build Back Better Act, aims to lower rising drug costs for people with private insurance as well as Medicare, such as the $35 monthly cap on insulin that President Biden talked about earlier this week. More broadly, though, drug costs are an issue because rising drug costs are contributing to higher premiums and fueling faster growth in national healthcare spending. So it is no surprise that a large majority of the public support government action on this issue, which may explain why we've seen proposals emerge from both sides of the aisle to address drug costs, and now the Build Back Better Act. Though, of course, some of the proposals continue to face strong opposition from the drug industry, as we'll hear about in a few minutes. Today, we're going to talk about the 6 main drug proposals in the legislation. These include, first, giving the federal government authority to negotiate drug prices for some high drug cost drugs under Medicare. Second, drug companies would be required to pay rebates if their drug prices increase faster than inflation for people with both Medicare and private insurance. Third, a new $2,000 hard cap on out-of-pocket spending and other benefit changes would take place for Part D. Fourth, cost sharing for insulin products would be limited to $35 per month for Medicare and private insurance. Fifth, cost sharing for adult vaccines covered under Medicare would be eliminated, and there would be improved access to adult vaccines under Medicaid and CHIP. And sixth, the Trump administration's drug rebate rule would be repealed beginning in 2026. 2 of these policies, the monthly insulin cap and the inflation limits, would take effect in 2023, which sounds like a long time from now, but actually it's a little bit more than a year from today. So to discuss these proposals, we pulled together an amazing team of experts to explain what's in the bill, what the public thinks about the bill, and what's likely to happen in the Senate in the next week or so, perhaps. We'll begin with Juliette Kabansky, Deputy Director of the Program on Medicare Policy at KFF, who will explain the key provisions in the legislation. We'll turn to Molly Ann Brody, an Executive Vice President here at KFF and Executive Director of our Public Opinion and Survey Research Program. We'll then turn to Jennifer Young and Chris Jennings, who will offer their respective perspectives on these drug proposals and the prospects for enactment. Jennifer is a partner at the health policy consulting firm Tarplin, Downs and Young. She served as a top official at the Department of Health and Human Services during the administration of President George W. Bush. And so she was deeply involved in all aspects of the Medicare Modernization Act, which included the Medicare drug benefit. Chris is president of Jennings Policy Strategies. He served as a health policy advisor in the Obama and Clinton administrations and has worked on prescription drug issues from the start of his career, if not even before then. And so just a reminder, after we hear from our speakers, we'll turn to your questions. So don't be shy about sending them our way. Take it away, Juliette.
Thank you, Tricia. So I'm going to dive right into explaining these provisions, starting with drug price negotiation. For context, Medicare is currently prohibited from negotiating drug prices in Part D, Medicare's retail pharmacy benefit, and pays the average sales price for physician-administered drugs in Part B. The BBBA would allow the federal government to negotiate prices with drug companies, but only certain drugs qualify for negotiation. These include single-source brand name drugs or biologicals that lack generic or biosimilar equivalents, and that are at least 9 years for small molecule drugs or 13 years for biologicals from their FDA approval date, plus all insulin products. Aside from insulin, a relatively small number of drugs would be subject to negotiation, starting with up to 10 Part D drugs in 2025, increasing to 20 Part D and Part B drugs in 2028 and later years. The upper limit for the negotiated price, aka the maximum fair price, equals the non-federal average manufacturer price, or AMP, which is the average price paid by wholesalers and retail pharmacies net of discounts, multiplied by a percent. The percent varies depending on the years from FDA approval, from 75% of AMP for drugs that are 9 to 12 years from approval, down to 40% for drugs that have been on the market for at least 16 years. Negotiated prices for Part D drugs would be available to all Medicare beneficiaries enrolled in Part D, and negotiated prices for Part B drugs would be made available to providers who administer them to Medicare beneficiaries. Next slide, please. The timeline for the negotiation process spans about 2 years. For negotiated prices available in 2025, the list of drugs selected for negotiation would be published on February 1, 2023. The selection is based on drugs that rank at the top of a combined ranking by total spending of the top 50 Part B drugs and the top 50 Part D drugs that are qualifying single-source drugs. The negotiation process between the HHS Secretary and manufacturers begins February 28th and ends November 1st. In developing an offer for the maximum fair price, the Secretary is required to consider certain financial and therapeutic factors related to each drug. Manufacturers can submit a counteroffer to the Secretary's offer, to which the Secretary would respond, and at the end of this process, the negotiated maximum fair prices would be published on the cms.gov website no later than November 15th, 2023. A financial penalty in the form of an excise tax would be imposed on manufacturers that do not negotiate with the Secretary, while a civil monetary penalty would be imposed on manufacturers for not offering the agreed upon maximum fair price. Next slide, please. So moving on to inflation limits. Under current law, Medicare has no authority to limit annual price increases for drugs covered under Part B or Part D. The BBBA would require drug manufacturers to pay a rebate to the federal government if their prices for single-source drugs and biologicals covered under Medicare Part B and nearly all covered drugs under Part D increase faster than the rate of inflation. The base year for measuring price changes relative to inflation is 2021, and the rebate amount equals the amount by which the manufacturer price exceeds the inflation-adjusted payment amount multiplied by the total number of units sold outside of Medicaid. This means that drug manufacturers would effectively have to rebate to the government any revenues from price increases in excess of inflation in Medicare or private plans. These rebate dollars would be deposited in the Medicare Supplementary Medical Insurance Trust Fund, and Medicare's manufacturers that don't pay the required rebate would face a penalty equal to at least 125% of the original rebate amount. Next slide, please. Now for details about Medicare Part D benefit redesign. Most importantly, as Tricia mentioned, under the current design, the Part D benefit has no cap on out-of-pocket spending for Medicare beneficiaries and places most of the financial responsibility for high drug costs on Medicare, not Part D plan sponsors or drug manufacturers. The BBBA would cap beneficiary out-of-pocket spending and reallocate liability for high drug costs. The bill adds a hard cap on out-of-pocket spending of $2,000 in 2024. It lowers beneficiaries' share of total drug costs below the spending cap, as well as their share of total premium costs, and gives beneficiaries the option to spread out their out-of-pocket costs over the entire year. For Medicare, the bill lowers the share of total drug costs that Medicare pays above the spending cap and increases Medicare's premium subsidy. For Part D plans, the bill increases their share of drug costs above the spending cap. And for drug manufacturers, the bill requires a 20% price discount on brand name drugs above the spending cap and modifies the discount that manufacturers currently offer below the spending cap. Next slide, please. Here you can see the cost-sharing structure for brand name drugs under current law and how the allocation of liability would change under the BBBA. I'll just draw your attention to the proposed change from an out-of-pocket threshold above which beneficiaries currently pay 5% coinsurance to a hard out-of-pocket cap above $2,000 in out-of-pocket costs. Next slide, please. The BBBA also includes measures to improve affordability of insulin and vaccines. The bill would require Medicare Part D plans and private group or individual health plans to charge enrollees no more than $35 per month for insulin products. Private plans would be required to offer this $35 copay on one insulin of each dosage form, that is vial and pen, and each insulin type, rapid acting, short acting, intermediate acting, and long acting. Medicare Part D plans would be required to charge no more than $35 for whichever insulin products they cover in 2023 and 2024, and all insulin products beginning in 2025. In terms of adult vaccines, like for shingles, many of them are currently available for free to most people with private insurance, but not for people with Medicare. Vaccines covered under Part D can be subject to cost sharing because Part D plans determine how much enrollees will pay for drugs that they cover. The BBBA would require that adult vaccines covered under Part D that are recommended by the Advisory Committee on Immunization Practices be covered at no cost. This would be consistent with coverage of most vaccines under Medicare Part B, such as the flu and COVID vaccines. The BBBA would also require Medicaid and CHIP to cover adult vaccines with no cost sharing for enrollees. Next slide, please. Finally, the BBBA would prohibit implementation of the final rule issued by the Trump administration that would have eliminated drug rebates or price discounts negotiated between drug manufacturers and pharmacy benefit managers in Part D. This rule was slated to take effect in 2022, but the Biden administration delayed implementation to 2023, and the infrastructure legislation signed into law in November includes a further delay to 2026. The BBBA proposes to repeal this rule as of 2026. Next slide, please. CBO estimates savings of around $300 billion over 10 years from the drug pricing provisions in the BBBA. About $80 billion in savings comes from the drug price negotiation provision, slightly more than $80 billion from the inflation limits, but the bulk of savings comes from repeal of the rebate rule. Next slide, please. These provisions would be implemented over the next several years, starting in 2023 with inflation limits and the $35 monthly copay cap for insulin. In 2024, the $2,000 cap in Part D and other benefit design changes would take effect, along with elimination of cost sharing for Part D adult vaccines. 2025 would be the first year of negotiated prices for up to 10 Part D drugs and all insulin products, and the provision to allow for spreading out-of-pocket costs in Part D would also take effect. In 2026, 2027, and 2028, the number of drugs subject to drug price negotiation would increase. On to you, Molly.
Thanks so much. Molly, can you take it from here?
Hello, everyone. Thanks, Tricia and Juliet, for getting us set up so well on this topic. Clearly, addressing prescription drug pricing has been on the policy and therefore on the public's agenda for a long time. That's Charlie, my dog. Sorry, she was so quiet while Juliet was speaking. Give me 1 second. You know, I think that's just part of the pandemic and doing Zoom events. So sorry about that. As I was saying, we've been polling on this topic for over 25 years. And there are some just long-standing things that we need to keep in mind with respect to the public and prescription drugs. The first thing is that healthcare costs and the affordability of healthcare, and particularly the affordability of prescription drugs, has always had great salience with the public. It really doesn't matter how we ask the question. If we're asking about a top priority, their biggest concern, their biggest worry, the top healthcare issue the public wants to see addressed, almost always and without sort of exception, healthcare costs and prescription drug costs continually rise to the very top of all of those lists. The second thing to keep in mind is that the public has really a love-hate relationship with the pharmaceutical industry. They very much appreciate and value the products that the pharmaceutical industry brings to them. They recognize that the new drugs make people's lives better, they make their own lives better, they make the lives of their family and friends better, and they really value that. On the other hand, they also believe that the industry is too focused on profits and that those profits are too high, and it's the profits that are a major reason why prices are so high. And as Tricia showed you before, given that so many people use prescription drugs on a regular basis, that they find the prices unreasonable, and that so many people have difficulty paying for them, when we give them any policy solution, virtually any policy solution that has been offered as a way to reduce costs, they sound appealing to people. Because at the end of the day, people just want their own healthcare costs to be lower. They don't really care that much about how policymakers go about doing such things. So Craig, the next slide, please. Thanks. So here's just an example. In this case, we've asked the public 11 different potential policy options that some have suggested would lower drug prices. You can see here that 10 out of 11 of those get over half of the public having a favorable view of those options as a way to reduce their own prices. Now, rising at the very top, those that are favored by more than 8 in 10 are things like making it easier for generic drugs to come to market, limiting how much drug companies can increase the price of prescription drugs each year to no more than the rate of inflation, placing annual limits on out-of-pocket costs for people on Medicare, and allowing the government to negotiate prices with drug companies. So many of the things that Juliet just talked about are things that are favorable among the general adults in the country. I'm going to switch and talk a little bit more about drug price negotiation now. Craig, you can change the slide. Mostly because it's one of the policy options that has more regularly broken through to the public, in that it's been the focus of discussion for a long time, and it's a policy option that people feel they can understand. Although certainly, as Juliet just pointed out, the details of that policy option make it far more complicated. But if we just look at, again, sort of the salience of the issue, earlier this year, when we asked people about a variety of healthcare policy things that Congress could focus on, you'll see here that allowing the federal government to negotiate with prescription drug companies to get lower prices came out at the very top of the public's agenda, followed closely by a variety of other policy topics. And in the next slide, what you'll see here is that we've been asking people about whether they favor or oppose this policy approach for many years. And you can see that, at least in this case, going back over 6 years across 8 different surveys, at least 8 in 10, the blue line at the top, of adults favored the idea of drug price negotiation. In a sense, it just makes sense to people. Why shouldn't negotiation be allowed? It's sort of a basic American concept of business. We negotiate for all sorts of things. We negotiate for our car buying. We negotiate for lots of other things. Why shouldn't we be able to negotiate, or the government be able to negotiate on our behalf for lower drug prices? So literally what you see here is that it continually gets the same reaction when we ask people about it. Sure, let's do that. Sounds like a good idea. And now moving to the next slide, though, what KFF tries to do in all of our polling is shed light on how the real world policy debate is playing out for people, and how that debate may be impacting opinion. And we do this as a way to make sure that those of you in the media, policymakers, and certainly the public at large has the same information at your disposal as we know the special interests often do, who certainly make sure that they learn what arguments and what messages are most impactful as they're trying to promote their favored policy positions. So what we did this time is we tried to mimic what the proponents and the opponents of drug price negotiation were saying in public discourse. We looked at their statements to the press and in their advertisements at the time. And what we did is, after we had gotten people's initial views on drug price negotiation, we read people, both the opponents and the proponents, made arguments, and then we re-asked their views on the policy option. So you can see here the arguments, we actually read them. The arguments against were that people opposed to allowing the federal government to negotiate prices with drug companies say this would have the government too involved and would lead to fewer new drugs being available in the future. On the other hand, the argument in favor, people in favor of allowing the federal government to negotiate prices with drug companies say this is needed because Americans pay higher prices than people in other countries. Many can't afford their prescriptions, and drug company profits are too high. Now, if you note here that that the net favor before hearing the arguments and after hearing the arguments was actually the same, meaning that these arguments overall didn't impact sort of opinion on this issue. Now, I should also note that we asked people how convincing they found each of those arguments as well. About 1/3 of the public found the argument against drug price negotiation very or somewhat convincing. About 8 in 10 found the argument in favor very or somewhat convincing. Next slide, please. Now here, even when we look at the results by partisan identification, we see that the net favorable towards the proposal does not change very much for Democrats, Independents, or Republicans. So on your far right, the net favor. So for Democrats, even before and after hearing the arguments, 9 in 10 favor this proposal. Independents, it's about 8 in 10. And for Republicans, it's about 7 in 10. However, those arguments did soften Republican support. So that is, before they heard the arguments, 44%, that dark blue part of that bottom, towards the bottom bar, 44% strongly favored drug price negotiation. Whereas after hearing the arguments, that share fell by 16 percentage points to 28% strongly favoring it, as more Republicans moved to the somewhat favoring that proposal. This certainly suggests that the opponents' arguments resonate more with Republicans than they did with others. Next slide. And lastly, but I think really importantly, I want to note that the basic premise behind the opponent's argument against price negotiation, that is that it's going to cut off innovation of new drug discovery, is not something that really resonates with the public overall or bipartisanship or age, as you see here. When we ask people which comes closer to their view, that drug companies need to charge higher prices to fund innovative research necessary to develop new drugs, or even if US prices were lower, drug companies would still make enough money to invest in research needed to develop new drugs, basically 9 in 10 pick the latter. That is, people fundamentally believe that drug companies make plenty of money to do both. They can innovate and they can lower prices. So I'm going to stop here for now, and I'll look forward to our discussion later and turn it back to Tricia. Thank you.
Thank you so much, Molly, and thank you, Julia.
Sorry about Charlie.
We love dogs here at KFF. Okay, so what I'd love to do now is turn to Jennifer and Chris and bring you both back on screen. And I want to thank you again so much for joining us today. We're really honored to have two veteran health policy experts, seasoned observers of the political process, help us understand what's in the bill and what's likely to happen. I think I'd like to start with a broad question to both of you. So the BBBA is in some ways a lighter version of the drug proposals that the House has considered in the past. It's scaled back both in terms of the negotiations provision and the inflation protection provisions. At the same time, it draws on bipartisan proposals that were developed in the Senate, and also the Republican proposal that was developed in the House. So I guess, Jennifer, maybe starting with you, now that we sort of see a lighter version of what we had seen before, what are the main outstanding policy concerns from a Republican perspective?
Sure, and I should start off by saying thanks so much for including me in this discussion. I'm honored to be here with you. I would say from the Republican perspective, the negotiation title that you were just discussing in the polling information really is a line in the sand. Even if you go back to the Grassley-Wyden negotiations of the previous Congress, Senator Grassley, among Republicans in leadership circles, is the one who has leaned most into an openness to action on drug pricing reform. And the package that he negotiated with Senator Wyden included inflationary caps. It included the Part D benefit redesign, including the cap on out-of-pocket costs. But negotiation for Republicans, going back to the origin of the program all the way back in 2003, negotiation was a line they were not comfortable crossing, because it changed the nature of a program that was designed to bring private sector management and the forces of the market harnessed by that private sector design into the program, and to inject that negotiation provision is one step too far. So that's been kind of a line in the sand. Around the other provisions, including the inflationary caps, we should be clear that those are not welcomed with open arms by the Republican conference by any means. But those provisions have been ones that have been at least subject of discussion and negotiation, again, as evidenced by Senator Grassley. There are certainly robust concerns about how you would structure those policies, when you would start them, how much look back would be included in them, but they are not as much anathema as the negotiation provision should be. And we should be clear that Republicans also enthusiastically support the concept of the Part D benefit redesign, especially bringing that out-of-pocket cap to the beneficiaries. Honestly, when the Part D program was first created back in 2003, we would have done that had there been enough money available at the time when the benefit was first being stood up. There was never any inherent programmatic logic to the initial benefit design. It was a reflection of how much money was available to be spent and trying to be smart and thoughtful about how that was initially stood up. And I think Republicans would welcome that D-benefit redesign as kind of a finally achieving what would have made sense from the beginning if it had been affordable.
Great, thank you. Chris, what's your perspective on this question?
On the Republicans' position?
Well, yes, what is your, no, I guess two things. What, are there outstanding concerns from a Democratic perspective?
Sure.
And, do you want to comment on what the concerns that Jennifer says that the Republicans have?
Sure. Well, one thing I would like to say is that, the Medicare Modernization Act was a predominantly significant Republican achievement. It was George Bush. It was the Republicans with a few Democrats. That most Democrats strongly opposed the policy at the time because it was such a privatized approach to dealing with prescription drugs, and it wasn't as generous as some of the Democrats wanted to have, as you'll recall, Trish, since you were part of that too. And Jennifer was part of an administration that in that environment had to implement the policy and frankly did a very, very good job of implementing the policy across the board. And it was not easy to do. But there are holes in that policy, as Jennifer herself just acknowledged. I would say that one of them is that there was an explicit prohibition to negotiate on prescription drug prices, as with virtually all the Democratic Party and the vast majority of Republicans and Democrats and independents in the public. And that's because there's a reflection of a sense of there's been a market failure, that the private sector actually has done a very good job where there's multi-source drugs, where they're competitors, they're able to negotiate and leverage better prices. But when there's not that type of competition, the Medicare program has to pay whatever the pharmaceutical company charges. And that doesn't make any sense to most people. And in fact, for the rest of the Medicare program, for hospitals, for physicians, for nursing homes, for home health agencies, the Medicare program uses its market leverage to limit the prices on behalf of beneficiaries and taxpayers for the administration of the Medicare benefit. This is just an extension of that. The last thing I'd mention is I hope, I'm sure I'm not going to, my hopes will not be realized, but I hope that this is an example of when we pass legislation, we know that we're going to have to build on, reform, improve, and strengthen it. It is not a pass a bill and we forget about it forever type deal. I hear these arguments, well, that was the deal. Well, there's no piece of legislation that does not need to be improved over a period of time. And I would argue that includes the Affordable Care Act and that includes the Medicare Modernization Act. And I would just hope that Democrats and Republicans could work a little bit more collaboratively. And Trish, I would like to answer a couple more questions, but I guess one last thing I'll just say is, as most people have watched this debate over the last several months, the policy has been substantially moderated. There's a far fewer number of drugs that are going to be permitted for negotiation. The indexing for the inflation has been moved up to a starting date of 2021. It used to be 2016. The savings that were to be achieved from this underlying policy has been lowered substantially. The impact on the industry has viewed to be moderated substantially. Wall Street is not overly concerned about this policy for the industry in terms of investment and innovation. And CBO has projected very little impact on innovation. So I know we're going to get into a number of those issues, but I think it's important to raise that context as we kick off this discussion.
Great. I'm going to move to a slightly different type of question. We've been hearing a lot about this bill going through a bird bath. And a bird bath might make sense to insiders who have worked in the Senate, but it may not make sense to real people who haven't. And I'm wondering if one of you might talk about the so-called bird bath that was named after Senator Byrd and what it means for a budget reconciliation bill. Who would like to take that on?
I'm happy to start us off, and Chris, please, of course, jump in. And I think, Tricia, you raised one very important starting point. It is the Byrd rule with a Y rather than the Byrd rule with an I. It is named after this late senator rather than our avian friends. The whole point to the Byrd rule is to ensure that when the Senate is considering a vehicle that has the procedural protections associated with it that reconciliation has, remember, reconciliation is a vehicle that strengthens the hand of a majority because it can be passed with only 51 votes. Reconciliation has to be protected from becoming a train that could attach all kinds of extraneous policies to it to allow the majority to get it through the Senate over the traditional institutional protections that would be available to the minority. So for that reason, Senator Byrd was instrumental in coming up with a kind of a shared agreement among the Senate that reconciliation has to be kept free from extraneous matter. And extraneous matters are defined as those that don't have a budgetary impact, because reconciliation is supposed to be about spending. So any policy that doesn't produce a change in outlay or revenues, or produces change in outlays and revenues that are only incidental to the non-budgetary components of the package. So this is intended to get out policy riders that don't have a cost effect. The Byrd rule is not self-executing. It has to be enforced, and you can waive it with a point of order that would require a 60-vote threshold in the Senate. So it's intended to protect, again, the prerogatives of the minority. So in this context, well, I should pause on that. Chris, anything I should have included in the description of the underlying rule?
No, I think you did great. I just say that when people say 50 versus 60 votes, this is otherwise known as the use of the filibuster to delay or constrain the ability of the majority to pass legislation with just a 51 vote threshold. So just want to put that in context, but it's perfect explanation.
And that was a really important addition. So Tricia, is it okay to then pivot to kind of—
Yes, I would. My next question that you were anticipating is, what does it mean in this context? What provisions might be challenged based on the Byrd rule? What can you tell us there?
Sure. So we are in the midst of a bird bath right now. On the healthcare provisions, the Democratic committee staff has had an opportunity to have their first conversation with the Senate parliamentarian. The Senate parliamentarian is the person who within the institution is charged with being the independent arbiter. She gets the first crack at whether something is a violation and therefore would be subject to this point of order. So the Finance Committee Democrats have presented their case defending the healthcare provisions that have already been walked through. Republicans within the next couple days hope to have an opportunity to present their point of view. And then at some point, ideally early next week, the parliamentarian would sit down with both Republicans and Democrats for a robust discussion of the provisions that are thought to be potentially subject to Byrd action. And in the drug pricing space, Republicans will be focusing their attention on policies that have a crosswalk with the commercial sector as being the policies that are most vulnerable to a successful Byrd action. So the first kind of lowest hanging fruit from the Republican perspective is the $35 copay for insulins as it relates to the commercial market, because that is outside the federal spending and therefore wouldn't have a direct budgetary impact. Application of that $35 copay within federal programs would be fair game under rule. Republicans will assert that the application of that same $35 requirement in the commercial market falls outside the realm of what is acceptable under the Byrd rule. So the first line of discussion that we would expect the Republicans and Democrats to have will be around that conversation. And just for you all to know, kind of going into that conversation, Republicans at least are bringing with them a sense of confidence that they're on very strong ground for asserting that that commercial piece is a bird violation. The second category of issues that will be debated, and I think there will be a more robust discussion between the Democrats and Republicans about the appropriateness, will be around the inflationary caps and their crosswalk with commercial market applicability, and whether those penalties include calculations that involve commercial market spending. And I think the issue will be, is that commercial market applicability so embedded in the underlying policy that it is fair game from the Democratic perspective, or still falls into that more problematic category as the Republicans will be asserting. So in a bird bath, these are complicated issues and they involve very technical line-by-line readings of the statute. We wouldn't expect the parliamentarian to rule in the course of a conversation, you're right, you're wrong, we're done, moving on. Instead, she will listen to the arguments and take it back and digest. So it could well be still a matter of several days before we get any ruling on those provisions. But in the healthcare, in the prescription drug world, I think those would be the policies we'd expect to attract the most discussion.
Chris, do you have any comments on that?
Yeah, just really quickly that I think they'll probably be there. There'll be the Democrat, the Republican, and probably a bipartisan meeting with the parliamentarian, and then there'll be a ruling. One other point that's probably worth noting, that even when the parliamentarian determines something is a violation, there are actions that the majority party can take. They can disagree with the parliamentarian, which is very, very rare. It would potentially create dysfunction in the Democrat Party, and it's probably akin to some of the dynamics that you're seeing with Senator Manchin's discomfort with institutional overrides. Okay, so that probably wouldn't happen. But the alternative approach could be, well, we're proposing a cap on insulin in the commercial marketplace. And yes, it will require a 60-vote threshold, but we're still going to require there be an amendment and a vote on that. And perhaps there'll be Republicans who might not like to vote against that and might actually support that because there's a lot of people who are on insulin who would very much benefit with a $35 copayment in the commercial sector. So I just want to say it's not necessarily the end of the road for a policy. Even if a parliamentarian rules against it, it just makes it a lot more difficult.
That's great. I'm going to ask another question, but as I'm doing that, I'm going to invite Molly and Juliette to join us because we now have a bunch of questions coming in from the audience. I guess my question is, if this process is slowing down a bit because of the parliamentarian, do you see a risk of no vote before the holiday recess? And if the Senate kicks the can to 2022, what do you see as the prospect for having this legislation passed before, say, the election?
Well, I'll start first this time, and then Jennifer will probably just applaud if that happens. So I don't know what we would do, but we would cry. As a general rule, I think there's a very significant desire by the White House and Democratic leadership to pass this before Christmas. There's a variety of reasons for that. One is that there's other work to do on a lot of other issues, both domestic and international, that can be distracting, and that time is not always in the favor of legislation that just gets pending for over long periods of time. And so there will be pressure. The policy has been negotiated in substantial ways by Senator Manchin and Senator Sinema with the White House throughout this process. And frankly, I don't expect many changes to the House passed legislation. There will be some, both from the parliamentarian bird bath that we've just discussed, as well as some amendments. But they'll be far and few between, and therefore, as long as we're in the general parameters of what has been discussed previously, I think that chances are great. If we get delayed, it's going to make it harder. But it is my personal view that failure isn't an option for the Democratic Party. They have to pass this, whether it's in December or January, it will be passed.
And I would just add from the Republican perspective that my Republican friends are clearly not in the driver's seat here. They are ready and waiting to go as soon as they are told to step to the plate for the birdbath conversations, and they'll be ready to go to the floor. But I think they would say that Senator Manchin's kind of repeatedly questioning whether, given what we see going on in the economy with the increase in inflation and the pressures that we continue to see in terms of the recovery, is this the appropriate time to undertake spending of this magnitude? And I think they would applaud him in his continued exploration of wanting to understand that connection better before beginning to the process of voting on this package.
Okay, some questions for everybody. I think Molly, you said you presented favorability on a lot of different proposals that were based on polls that were conducted before the BBBA became real to all of us. Does the public know what's in this bill and the various drug provisions and what they would actually do?
I think it's easy to say highly unlikely that they know this level of detail, right? They've certainly heard about it. I would say they know that there's, big things going on that sound good to them in different ways, but the details are just beyond what an average person just has the interest in paying attention to. I mean, interest and capacity. I mean, there's a lot of things going on in people's lives right now, right? They're worried about the ongoing pandemic. They're worried about what it means with, going to school, the holidays, the inflation, food on the table, real life stuff. And as important as all of these policy debates are, and as meaningful as they can be to their individual lives, it's hard to follow the nuances of these policy debates. And it's not just hard, they just make choices, right? Choices about what to pay attention to. So these are really important topics to people. They care a lot about seeing that something is done to help address their affordability concerns. They want to hear that that's going to happen. They look for those sort of outcomes. But I think it's unlikely that people are paying attention to the level of detail of particularly the conversation we're having sort of today.
Okay, I'm going to go to some questions from our readers. Yep.
So I was just going to say that one thing that we've learned about, I'm sure Molly would agree with this, that if anything, the public is skeptical that Congress will actually act on prescription drugs. They'll be somewhat surprised that they did because they're so cynical, but and there's a track record. Democrats have been talking for 25 years about negotiating Medicare drugs. Donald Trump has been talking about negotiating drugs. Where is it? Stop talking about it. Let's walk the talk, right? And so that sense is out there. I think that there's going to be some encouraging signs from the public if the Democratic Party can break through on communicating that this actually is going to happen and that they can show and feel the benefits of the underlying policy. This is why I think the president just this week decided to highlight prescription drugs as a standalone issue to begin that process of informing the public.
Okay, well, so I'm now going to ask a question and I think I'm going to know the answer, and it's probably going to be coming from Chris, but anybody can chime in. What about extending negotiated prices to the private sector? Someone asks. And a related question, why isn't the federal government able to negotiate more drugs than just the 10 rising to 20 that's in the legislation?
Well, you can either have legislation that is a down payment towards an ultimate nirvana, or you can not have legislation. And I think this policy represents even a compromise amongst Democrats. Remember, there's very few votes to spare in either the House or the Senate. and many of the more conservative Democrats had concerns about being overly aggressive, particularly in the commercial space. And indeed, Jennifer has raised this, but it's possible that the parliamentarian wouldn't have sanctioned negotiation in the commercial sector in particular. It might have been even harder than the inflation indexing policy that we've discussed. So I would just say, yes, there is aspirational to build on and do better, just as this legislation represents a build on to do better than the original Medicare Modernization Act from my perspective. And I presume that in years to come, we'll do more, particularly if the industry does not take a signal from this legislation to be a little bit more sensitive about launch pricing.
Okay, I'm going to switch to Medicare Part B drugs, which have gotten less attention from all of us. So these are drugs administered by doctors, and these would be subject to negotiations. We have a question here about, is the high cost of drugs driving the historic increase in Part B premiums for 2022? Juliette, do you want to take that one?
Sure. This is definitely a factor at play in the large Part B premium increase that we are seeing for 2022. Medicare said in announcing the 2022 premium that part of the increase is due to the expectation that if Medicare issues a coverage decision to cover this new Alzheimer's drug called Aduhelm, which has a list price of $56,000 a year, that could cause a substantial increase in Medicare spending as a result of covering that one drug alone. And as a result, Medicare needs to build up its financial reserves in order to have the funds available to pay for Aduhelm if Medicare issues a coverage decision. And just to sort of remind everybody, Medicare is undertaking a process now called the National Coverage Determination Process. They will issue a decision, a preliminary decision in January about Medicare coverage, and that will be subject to a public comment period. So by April next year, we'll know what Medicare's decision will be with regard to coverage of Aduhelm. But because the premium needs to be set in advance of the year starting, that is why, at least in large part, why the Part B premium increase is jumping so much for next year.
And if I could just quickly, if you don't mind, follow up on that, I would say one of the dynamics that I think took people aback when the actuary made that recommendation about the Part B premium is when looking at the cost, again, using the specific example of Aduhelm, are people also thinking about, as a result of spending on a product, are we going to see a delayed progression to admission into nursing homes? Could there be savings associated with fewer ER visits as caregivers wrestle with treatment of sometimes difficult to manage symptoms associated with the dementia progression? So I think it is important for policymakers, including within CMS, as we think about the costs associated with a new breakthrough product. And Aduhelm may not be it, but as we all hope that one of them is coming in the Alzheimer's space, it should be viewed more comprehensively, because the ideal here is to see some of those systematic savings as well as the cost of the drug itself.
And I'm going to stick with Aduhelm and Part B for a second. We have a question about, everybody's talked about this out-of-pocket cap that's super popular. Does that apply to Part B drugs also? Juliette?
No, Medicare doesn't have an out-of-pocket cap for expenses under Part A or Part B. So people who are in traditional Medicare, unless they have a source of supplemental insurance that helps them with their Medicare cost-sharing requirements, or if they're in Medicare Advantage plans, all plans have an out-of-pocket cap, but under Medicare's current structure, there's no out-of-pocket limit for Part A or Part B expenses.
Okay, this could, anybody want to take this one? Okay, so Aduhelm is a really interesting example, because Aduhelm was just approved by the FDA this year. So the laws, as Juliet described, would say there's a 13-year period after approval before the secretary would negotiate drug prices. I guess what I want to know is what in this legislation might affect a high-priced drug like Aduhelm if it comes on, if it's high-priced, but it's approved, say, this year. Juliet, you want to go for that one too?
Sure. Well, I mean, Aduhelm is kind of the example of a drug where the provisions of the BBBA really wouldn't have much impact in terms of its price or what patients pay out of pocket, at least in the next, decade plus. It's an infused medication covered under Part B. So if Medicare decides to cover this drug, the proposed $2,000 cap on out-of-pocket costs wouldn't apply. In terms of the negotiation provision, because of the bill's exemptions on relatively recently approved drugs, Aduhelm would be exempt from negotiation for 13 years after its approval date. So basically, we're looking at 2034, 2035 at the earliest. And in terms of the inflation provision, that could help keep the price increases for Aduhelm in check. Biogen, which manufactures the drug, has said they won't increase the price for the first 4 years the drug is on the market. But after that, assuming the price does increase, the proposal to require rebates for price increases greater than inflation should help to keep price growth in check, which would then obviously translate to out-of-pocket savings for patients with Medicare in the long run.
Great. Here's a question I think maybe Chris and Jennifer might disagree about or have different points of view about. The prices, this is about the term negotiated prices, and the fact that there's a formula. How is that not price setting? Is it negotiation or is it price setting?
Oh, I'll take the easy answer. It's price setting.
I kind of thought you might say that. Chris?
Well, there's a price limit, and then there is a process for evaluating the value of the product and negotiating with the secretary. So I would call it negotiation. And in fact, I would call it closer to negotiation than what most of the rest of the Medicare program has, which are direct payment rate limits. And so, it all depends on how you want to view this. But what I think is unacceptable is for the Medicare program and the beneficiaries and the taxpayers who pay for it to pay whatever price, whatever drug company wants to charge for whatever drug. I mean, and the reason why this has created problems is we've had a market failure that has created huge affordability issues for taxpayers and beneficiaries alike. And we can either not do anything and continue to say that's fine, or we can start acting to do something about it.
Okay, I'm going to do one quick question, and then I think we do need to wrap up because it's at time. But we have a question about Congress. If the Build Back Better Act stalls, and I know, Chris, you said it wasn't going to because it couldn't. If it does, what are the chances?
No, I said it could stall, but it will still succeed.
Exactly. Okay. So if in this hypothetical world you're not right, what are the chances that the drug price provisions and maybe related health coverage provisions would move in 2022 as a separate bill?
Well, I will say, and I guess I would probably turn to Molly on this one. The most popular provisions of the Build Back Better legislation are weighted substantially to healthcare and affordability issues. So if that unacceptable situation occurred and that and BBB was not passed and enacted into law, I would think there would be an effort, and I would say that there would, but it would still be constrained by the limit. It's not like it could go much further to the left in terms of the current. Like if you pulled out certain key popular healthcare policies, you could probably pass something, but you couldn't make them more progressive because you would still be limited by the same one vote problem in the House and the few vote problem in the Senate and the few vote problem in the House. So some people say, so let's just have a big new healthcare package. We're still limited by that political reality as well.
Yeah, and I would just, agree with Chris that those are incredibly popular provisions and things that are salient to people. As I said before, these are things that are on people's mind. They will look for whether their representatives did as promised or didn't do as promised. That could, affect sort of enthusiasm for the midterm elections and could, be used in conversations to rev up bases and to work on turnout for both sides, right? But yes, they are very popular and salient to people. So they are not issues that I expect the American public is going to let representatives forget about in the long term.
Thank you. This has been great. And I think the people, at least the panelists, we could all talk about this all day long, but we're going to let our audience go. I want to thank each of you so much for a really great discussion on a complex and important topic. This matters to millions and millions of Americans. I want to thank the audience for sending in really thoughtful questions. I'm sorry we couldn't get to more of them. We at KFF will continue to be tracking and analyzing these issues and provisions in the BBBA as they move forward into the future. As a quick reminder, this web briefing is being recorded. It will be posted later today. And if you have registered for the event, you will get a notice that it's been posted. Thanks again. I really appreciate it. Take care and have a great day.